hearing from Frank Uke. He's one of our chief residents. He completed his education with undergrad at Johns Hopkins and medical school at Icahn School of Medicine. Today he's going to be presenting spine conference.
Am I on presenter mode?
Yeah, looks good.
Okay. Good morning. I'm Frank. I'm one of the chief residents. I'll be presenting spine conference today. Fortunately, it's not about preventing infections though in the spine. So we'll start with a patient presentation. This is a 65-year-old male. He has a history of COPD, diabetes, prior C4-6 ACDF, which was done here at MSH, and prior reported history of lumbar fusion in Bangladesh in 2021, and presents with severe back pain and right greater and left radiculopathy, weakness, and difficulty walking on exam. He's full strength in the uppers and lowers. He's approximately full strength, but distally on the right, he's 4 out of 5. All right, so let's go down to our interns. Emily, can you read this? He got an MRI as an outpatient. Can you read this MR for us?
So we have 3 panels here of a sagittal MRI, lumbar spine. Looking at the T2 sequence in the middle panel, I'm definitely seeing moderate disc herniation, L2-3 most prominent, also L3-4, and leading to some canal stenosis.
Okay, and what about the foramen here at 4-5?
And the foramen at 4-5. So I could definitely see pedicle screws from the prior surgery in the vertebral bodies, and then the foramen looks like there's definitely some deformity at 4-5.
I wouldn't say if there's any deformity yet, but I would say that there is significant amount of degeneration between, in the lumbar spine throughout, but it's specifically at the right 4-5 foramen. There's a significant amount of foraminal stenosis as compared to the left. There's some artifact from the screws. Okay, so and here's the midline cut from L2-3 showing severe stenosis. Any other imaging that you want, Emily?
Yeah, I'd also want to see the stability of the vertebral bodies as well.
So what kind of scan do you want?
So I would want a lumbar flex X as well.
Okay, and a CAT scan. So here's the CAT scan. Let's go to Chi. Chi, can you read this CAT scan for us?
Yes, so this is also a 3-panel. We see the sagittal view of a CT lumbar spine. You can see that there's been a prior fusion from L1 to L5, it looks like. And then we also see the bony degenerative changes, as Emily mentioned earlier.
Okay, couple other things to note. I think so. This is S1 down here. So there's an S1 screw here. So this is likely a fusion from L1 to S1. You can also see that screw is slightly misplaced, and it looks like it's in the disc space of 5-1, which is what I'm trying to show in this cut here. Patient also has a fusion anteriorly from L5 S1. And the other thing you can note laterally, there isn't any bone graft that you see or any evidence of fusion between those levels. And there's also a prior bottom of L3 to the top of L5 laminectomy done. Okay, so then you asked me to get an X-ray, and then you see this X-ray. So can you describe this X-ray for us? Chi.
So we see the coronal and sagittal view, I guess AP and lateral view of the standing X-ray. And we can see that the fusion at the top is only on the left side, from L1 to L3. And then there's fusion bilaterally from L5 to S1. And on the right, there's also fusion at L4 as well.
So
And
a fusion describes the union of two bones. In this case, we're not 100% confident whether this has really been fused or not. I would use the word instrumented. So the patient's instrumented from the left side from L1 to L3, and then on the right from L4 to S1. On the left there, it seems to have skipped a screw here. So this is a slightly odd construct. You normally don't see this type of construct. But sometimes you do see it from other countries where the patient has to pay for their own screws. And so oftentimes you do sometimes can see these unilateral screws. And also in certain practices, let's say you're doing a degenerative 5-1 ALIF and perk screws, sometimes the ALIF can be done and then stabilized with just unilateral instrumentation posteriorly. So that's not super uncommon to see. All right, so before we do any surgery, any correction, we have to know all these measurements that we've been through multiple times: the sagittal vertical axis, the lumbar lordosis, the sacral slope, pelvic incidence, the pelvic tilt, and as well as the coronal balance. So we've been through this multiple times, so we can just fly through this. So the coronal plane decompensation is the distance between the C7 plumb line and the central sacral vertical line. And this shows you which plane, whether to the right or left, they're coronally imbalanced. The SVA, or the sagittal vertical axis, you drop a plumb line from C7, and then you measure the distance from that plumb line to the posterior superior aspect of S1. And this should be within plus minus 2.5 centimeters, but we'll get to that later. And then pelvic incidence, we've seen this multiple times, but you draw a line from the midpoint of the femoral head up to the midpoint of the sacrum, and you draw a perpendicular line to the center of the sacral end plate. And oftentimes changing PI is very difficult unless you do a sacral osteotomy. And the normal PI for this, for most patients, falls between 45 and 65 degrees. And the pelvic tilt, this is calculated from the angle drawn from the midpoint of the sacral end plate to the femoral heads, and then a vertical plumb line drawn upwards. And this should be between 0 and 20 degrees of pelvic tilt. The sacral slope is the line drawn by an angle drawn by the line from the sacral end plate and a horizontal line. This should be between 30 to 45 degrees. And then lumbar lordosis is the angle between S1, the top of S1, and top of L1, and this should be between 20 to 45 degrees. And so we often talk about a PI and LL mismatch when we're looking at deformity cases. So Noah, what should a PI-LL mismatch be for a patient to be considered balanced? Oh,
Can everybody hear me?
Yeah.
Okay. So you want them to be plus or minus, I believe, within 10 degrees of each other.
Plus minus 9 to 11 degrees. And so multiple studies have shown that reducing this PI-LL mismatch within 9 to 11 degrees significantly decreases the rate of proximal junctional kyphosis, adjacent segment disease, and failure of the construct. And so we'll talk more about proximal junctional kyphosis in a minute. So I did all the measurements for us. So the PI is about 42 degrees. The lumbar lordosis is low at 23 degrees. And the L4-S1 segmental lordosis is 19 degrees, and the pelvic tilt is 20, so which is kind of right on the cusp of being normal. And so the PI-LL mismatch after subtracting 9 is about 10 degrees of mismatch. And so the lumbar lordosis at L4-S1 should account for approximately 66%, or about 2/3 of the total lumbar lordosis from L1 to S1. And multiple studies have confirmed this and shown that meeting this criteria of almost 2/3 lumbar segmental lordosis decreases the rates of adjacent segment disease and reoperation. And multiple studies have shown this in JNS Spine and other journals. And so our patient has a PI, like we said, has a PI 42, and they're mismatched almost 10 degrees. And so what is our goal of surgery then? Let's see, Matt.
from a deformity correction perspective, would you have to correct? Yeah, 10 degrees, right?
Yeah, so bring the mismatch down to 0 degrees. And what else? You want to also decompress L2-3 since you're there. And he has severe stenosis L2-3. And so where should this correction occur? We just talked about it. And ideally, this correction should occur at L4 to S1 to bring the segmental lordosis closer to 66%, because currently his lumbar lordosis, or L4 to S1 segmental lordosis of 19 degrees is only 45% of his total lumbar lordosis. And so he's currently mismatched. So if we can get the 10 degrees of correction at L4 to S1, then we can bring the segmental lordosis closer to 66%. And so our operative plan, how are we going to achieve this, and what surgery would you offer? Let's see, Abi.
All right, can you go back to the scan?
Yes. Which scan do you want to see? This one or this one?
That one seems okay. All right, so for this patient, overall, I'm going to offer a revision of the original construct. Specifically, since we're trying to increase the lordosis, give the patient more lordosis from the L4 to S1, we can do Pontes at L4, L5, try to give the patient more lordosis, and then instrument. Obviously, I would put bilateral. I would instrument bilaterally in this case, as well as I would also do pretty significant decompression at make sure foraminal decompression at 4-5, and also at a higher and also maybe some central decompression at L1, L2, L2, L3. Since I'm already extending my fusion, I'll extend my laminectomy up there to give that central decompression to the thecal sac. So I would offer overall a revision. I can do a revision L1 to S1 fusion. That would be my most conservative offering, would be reasonable. In this case, L1 to S1 with the central decompression of L1, L2, as well as a foraminal L4, L5 Pontes, and a foraminal decompression of L4, 5.
Okay.
You could also extend the fusion up if you're worried about adjacent segment disease.
All right, very good. Yeah, so that's very similar to what we described. So we offered a T10 to pelvis instrumentation and fusion, L3-4 and L4-5 T-lifts, and then L3-4 and 4-5 Ponte osteotomies, like you had described. Okay, and so this is the goal of surgery. The goal of surgery is to get 2 cages in from L3-4 and L4-5 and remove and do Ponte osteotomy, remove the facets from L3-4 and 4-5 in these red boxes here. All right, Alex, future barrel lateral fellow. Can we offer combined anterior or lateral options?
It's possible in his case. I only saw bony fusion anteriorly at 5-1. I think potentially higher up would be better, especially at the levels where it's collapsed, like at 2-3, where we saw there's foraminal stenosis and he needs some height. I don't think it's unreasonable. Again, it depends on your index procedure to see how you want to stage it. But
so what would you do if you could offer lateral or anterior approaches?
So there are a couple ways to do it. I think there isn't significant coronal deformity from the standing films. So in terms of which way you would choose, I mean, you could approach it from the right. You can do potentially 2-3, 3-4, 4-5, standalone lateral, and then back it up with Pontes at 3-4, 4-5.
Are you going to be able to create any lordosis with the rods in there?
No, sorry. This is after you're taking all the instrumentation out. But I'm saying you would put the lateral interbodies in first before doing the posterior instrumentation. So
you'd have to do a back front back, basically, right? You'd have to release all of these screws and do the instrument and do your lateral instrumentation. You could do an A-lift at 5-1. However, you'd have to break this fusion construct, which is challenging to do. And so, and you could theoretically just do a L3-4 lateral because that area is not fused, and there wouldn't be any screw on screw resistance. And so you could do that and then offer a posterior revision. But like we described, we want to get most of our lordosis from 4 to S1. And since 5-1 is fused, our best option is to go to 4-5. All right, so there are some anterior lateral options, but it would require much more surgery for this patient. So the Schwab grades we talked about many times, but a grade 1 is a partial fastectomy, a grade 2 is a complete fastectomy, or Ponti osteotomy. Grade 3 is a PSO or pedicle subtraction osteotomy. A grade 4 is an extended PSO where you take the disc above. And then grade 5 is a total vertebrectomy and taking the adjacent disc superiorly, inferiorly, and then a Schwab grade 6 is multi-level vertebrectomies.
Okay.
And so how's a Ponti osteotomy performed? And so after subparalysis dissection is performed out to the TPs, the joint capsules are removed, the spinous process and the basal lamina are removed, and then the inferior articulating process is then removed, and then the superior articulating process after that, which is hidden underneath the IAP, and then the ligamentum flavum is resected, and then the osteotomy is closed. So the way we are taught here, this is the exiting nerve root in orange, and so we've been taught to take a osteotome instead of a drill, and create a fracture line across the pars here, and then the next cut is to do a fastectomy of the IAP. So and then cutting across the inferior articulating process, which then removes this IAP and exposes the SAP below. And then you take the same osteotome, and then you can break the SAP here, which then allows you to remove this entire facet joint. And so how do we close this gap? And so this gap can be closed posteriorly, usually using a lordotic rod and then compressing across the osteotomy, shown this here in this diagram. So you can place the curved rod or lordotic rod and then close the gap using a compressor or just by cantilevering. The other option is to segment this or make this fusion more robust and place an anterior graft, whether it's a lateral, anterior, or a TLIF, and increase the height of the anterior column, and that will increase the fulcrum anteriorly and allow you to close this gap better. And so after doing all the surgery, we got a post-op CT, and you can see that we achieved the goal that we were looking for. And here's a standing scoliosis films afterwards. And then here's all the data. So the PI remained the same, but the lumbar lordosis increased from 23 degrees up to 43 degrees. And the segmental lumbar lordosis at 4 to S1 went from 19 degrees to 31, which is an increase from 45 degrees to up to 78, which is greater than or equal to the 66, or getting the majority of the lumbar lordosis at 4 to S1. And then the pelvic tilt decreased from 20 to 10, which is a much more balanced number, and the mismatch went to 0. And so here's the pre versus post-op films, and you can see that we definitely increased the lumbar lordosis and given him a much more gentle curve into the thoracolumbar junction. And we achieved that with TLIF cages here and the Ponti osteotomies. So the patient did well and recovered to full strength, and then we went to acute rehab. However, let's just say hypothetically, the same patient now represents with severe back pain, thoracic back pain, and says he can feel the rods rubbing against his skin. If that were to happen, let's see, let's go back down. Emily, what do you think is going on before you even get any x-rays or anything?
Yeah, I anticipate it's more instability of the construct. So I guess like a kyphosis with the pathological kyphosis with the rods then pushing up more superficially.
Yeah, so, or we call that proximal junctional kyphosis. So let's say you get the x-rays, and this is not this patient, this is a hypothetical occurrence of this patient, and you see this here. And so you can see that there's focal kyphosis across the junction at the instrumented vertebral level and above. All right, and so what is the definition of proximal junctional kyphosis? Let's see, Abi.
So as the name suggests, it usually happens at the junction the junction between an instrumented or a fused spine and a non-instrumented or a non-fused spine. Sometimes you can have two blocks of fusions that are not connected, and you can have a proximal junction kyphosis between them. So generally, it happens that either a thoracolumbar region or just thoracic region, where the fusion inferiorly creates a large lever arm over which the thoracic spine, basically the kyphosis, due to the weight of the body, is not
Okay.
able to be pulled back by the muscle.
Okay, that's a good way to describe what proximal looks like on X-ray, but there's actually no perfect definition for PJK, proximal junctional kyphosis, but this has been the generalized accepted definition, which is that the sagittal Cobb angle is equal to or greater than 10 degrees, and there has to be greater than 10 degrees of kyphotic change than the preoperative measurement. So, and how does this occur? It can occur from vertebral fractures of the upper instrumented vertebrae or UIV plus 1, which is a level above, subluxation or dislocation or spondylolisthesis between the UIV and UIV plus 1, failure of instrumentation, et cetera. And so how does this how do we measure this? So this is a Cobb angle, like we said, between the inferior end plate of the UIV and UIV plus 2 usually. So here's the inferior end plate of the UIV, or the uppermost instrumented vertebral level, and then the UIV plus 2. And then this angle, or this Cobb angle, is what gives you this PJK degree of PJK. And so when does it occur? If it occurs, it tends to occur within the first 3 to 6 months, but up to a year after the index surgery. And the incidence is super highly variable in the literature, from 6% all the way up to 68% for adult deformity cases. And then so if we talk about proximal junctional kyphosis, we always talk about proximal junctional failure in relationship to that. And what is proximal junctional failure, Matt?
I thought it was PJK plus like hardware pullout.
So hardware pullout can still be PJK. So proximal junctional failure is any type of symptomatic PJK requiring revision surgery. So if they go for surgery and they need revision, then it's considered a proximal junctional failure, because sometimes you can manage proximal junctional kyphosis conservatively and may not need surgery to repair it. And although the generalized accepted PJK rate is approximately 30 degrees, whenever anyone asks you about PJK, it's approximately 30 degrees. The rate of PJ failure is much lower, around 2 to 8 degrees. So meaning that not every PJK requires surgery to repair it. And so the surgical risk factors for developing PJK are many, including age greater than 55, obesity, disruption of the posterior soft tissues at the UIV or UIV levels above the UIV. And it's 3 times more likely to occur in combined front-back procedures when compared to posterior only. And the extension of the fusion down to the sacrum or the pelvis. However, a lot of these studies didn't control for preoperative deformity, and your choice of the upper instrumented vertebral level also correlates with PJK and overcorrection. So, and why should we try to prevent PJK? Because PJK has very high healthcare costs, readmitting the patient, having increased length of stay, reoperation rates and costs, and patients could develop severe neurologic deficit that could be transient or permanent. So we'll talk about all the ones that we talked about and how we can potentially prevent them from happening. So posterior tension band disrupting the PLC, especially the intervertebral elements, the interspinous ligaments and the facet capsule, and the attached muscles and ligaments, increase the risk of PJK. And so how can we change this? How can we make this better? So there have been some methods that have been studied to prevent disruption of or strengthen or prevent disruption of the posterior tension band. And one option is to create a soft landing at the UIV and UIV plus 1 and 2. And that's usually the laminar hooks, transverse process hooks, pedicle hooks. These are older instrumentation that existed before pedicle screws. However, they're coming back in deformity because you can create a much softer landing and spread the load across the top screw across a much softer laminar hook that allows some freedom of movement and prevents the upper instrumented level plus 1 to spondylolisthesis forward. You can also recreate the posterior tension band. So in the past, Merceline tape has been used to wrap around the spinous processes to strengthen the posterior tension band, like we see in this little diagram here, and then that's been tied to the rod to prevent the upper levels from kyphosing. And using this theory of Merceline tape, spinal instrumentation companies now have developed tension band devices that attach to the UIV and UIV plus 1 or 2, and that attaches to the construct using a lateral connector here. And so these bands are basically sewn through the spinous processes, and they're pulled back and tensioned onto the actual construct itself to prevent PJK. Dr. Lanke has just published this paper about reducing the amount of exposure in the upper instrumented levels if you don't need to do any decompression. So this is a diagram of the sacrum here and the the lower thoracic levels here. And the exposure is done from sacrum up to L1, but then the top 3 levels, UIV -1, -2, so T10, 11, 12 are not exposed. The ligaments are preserved, the muscle attachments are preserved. And so how do you actually end up instrumenting these levels then? And so we take a page out of Wilsey's approach, and an avascular intermuscular plane is developed between the multifidus and the longissimus muscles, which is considered Wilsey's approach in the lumbar spine. And the transverse processing facet joints are exposed from a lateral trajectory. You can see here, Dr. Lanke's put his finger down and try to feel the transverse processes, and therefore the entry points for those screws. And then a small retractor is inserted, and the pedicle screws are inserted through the small opening, and then the rod slides up through the muscles. And so this is another technique to try to preserve the posterior tension band. Combined anterior posterior approaches, really, there's no way to avoid it. Sometimes the patients need front back surgery, but they are definitely really associated with higher rates of PJK. And this is not that well understood due to confounding patient factors. For those who actually need anterior posterior approaches, they may just require more surgery. And the theory is that it's potentially due to the increased construct rigidity that causes the PJK. And so extension down to sacral pelvis have much higher rates of PJK, like I said, but these studies didn't really control for preoperative deformity. And so likely the fusion to sacrum is associated with just higher levels of preoperative deformity. It might not be an independent risk factor for developing PJK. And the choice of UIV also correlates with advanced PJK. And patients with advanced PJK tend to have actually lower numbers of levels fused, which makes sense because you create a much more mobile construct above and below for degeneration. And most likely, they're more likely to have a upper UIV in the lower thoracic spine between T10 and 12. And specifically in the thoracolumbar junction seems to have a predisposition to vertebral fractures. So one theory is to extend the fusion then to during the index surgery to extend the fusion to include levels with baseline segmental kyphosis greater than 5 degrees at baseline, instead of stopping the construct at those levels where you think it's going to already break down and predict PJK. So that's been one theory, but of course, then you require much larger surgeries and may have to even instrument through the thoracic kyphosis, which then is a much larger surgery than you originally anticipated. And preoperative assessment of bone density is also very important for anyone undergoing adult deformity. And UIV and UIV plus 1 fracture are one of the most common causes of PJK. And so these patients should be evaluated by endocrinology for consideration of bone density medications for 3 to 6 months preoperatively. And ideally, you would have a DEXA scan, but recently there's been some data on using CT bone mineral density to substitute instead of getting a DEXA scan, which is often difficult to do, one as an inpatient, but even as an outpatient. And so we can use hounsfield units measuring just off a CAT scan. And so what you would do is you would go to the axial slices of the vertebral levels you're about to instrument preoperatively, and you use the ellipse tool to ellipse around the center of the vertebral body without including the sclerotic parts of the bone. And a hounsfield unit of 120 or less is typically associated with osteopenia. This is the CAT scan from our previous patient, and he has a decent hounsfield units of over 200, and so we decided not to use any segmental augmentation. And so getting the segment augmentation, one way to potentially prevent fractures from happening at UIV and UIV plus 1 or 2 is to prophylactically treat those levels and do the kyphoplasties during the index surgery at the level or the level above to try to prevent fractures from occurring. But you can also do them for treatment for PJK as long as they don't have neurologic deficits. You could try to do kyphoplasties at those levels to prevent further PJK from occurring. Intraoperatively, we can also use fenestrated screws. So this is a patient that we did at Elmhurst who had very low hounsfield units of 90. And so we use fenestrated screws, which have cannulations at the bottom portion of the screw. And once you confirm that the screws are in good place, you can inject cement through them and to try to prevent the screws from 1, pulling out, and 2, fracturing the vertebral body. And also finally, overcorrection has much higher incidence of rate of PJK, especially when you overcorrect them. And for example, this patient on the left looked like they were overcorrected. Their SVA is almost 0. C7 SVA is almost 0. And you can see a few months later, they create they start to PJK. And the tendency to restore the SVA to 0 may not be optimal for all patients. There's been some recent data that you should correct the SVA based on the decade that they were born. So for example, a 70-year-old, you don't want to perfectly match them to an SVA of 2.5 centimeters or 0 centimeters. You can correct them to just 7 centimeters. An 80-year-old, 8 centimeters, and so forth. And so this is where pre-bent rods come in. This is sort of the next level to see if we can prevent overcorrection. So one study asked 10 experienced spine surgeons to bend 3 rods at 40 degrees, 60 degrees, and 80 degrees without a template. And the average rod was actually overbent by almost 20 degrees of the desired curvature. But when you gave them a template, when you gave the surgeon a template, they were within 2 degrees of the actual desired curvature. And so most recently, actually, there's been a lot of AI use to predict the change in the thoracic curvature and therefore prevent PJK from occurring, and then use the pre-bent rods to optimize the sagittal balance. So for example, this patient has standing scoli X-ray here. This is put through the AI system program, and the AI predicts what will be the most optimal sagittal balance, a lumbar lordosis. And then it also predicts what the thoracic kyphosis may become once this rod is in. And then this rod is then custom bent and custom made for this patient specifically. And then during the surgery, you can use this rod to actually instrument the patient, and they have much lower rates of rod fractures. So the future directions for PJK, we need to better understand the optimal spinal pelvic parameters to prevent PJK. Currently, there's no real good studies to show the difference between PILO difference, whether you match them plus 9 degrees or minus 9 degrees. That would require a much larger, a very large patient population and significant amount of surgery. And likely will also have to be age specific. We don't want to be correcting 70, 80-year-olds down to 0 centimeters of SVA. And so many of these studies also on PJK, they don't control for preoperative deformity. And so that's another thing future studies could look at. And there's no ideal studies on the apex of the lumbar lordosis relative to the pelvic incidence and its relationship to PJK when instrumented very high up. So I'd like to just thank Dr. Patterson, our leadership, Dr. Patterson, Shreve Style, Dr. Mako, for giving me that chance to spend 6 months doing Mindfolded, and then all of our spine faculty who have let me help them on their cases. Thank you.
Frank, that was an outstanding presentation with value to beginners and experts alike. Another example of how you've become a really important part of our spinal education and our clinical care and our service. But the 2 topics of proximal junction kyphosis and really that lower lumbar lordosis, the vast majority of spinal fusions are done by non-deformity, quote unquote, surgeons in the lower lumbar region. And if that gets set in the wrong level, it can actually lead to major problems, as you showed in that example. I think my other quick comment is on the infection topic. I think every single one of us in the spine service, residents and attendings and APPs, can play a role in this. And so we're going to set up a working group that meets quarterly, and will involve Susie, anyone from the QA process, and others to look into this topic. And there's a lot of things we can do with this. So thanks everyone in advance. But thank you, Frank, for the education.
Thank you.
Hey, Frank, that beautiful talk, that image you showed of Lenke retracting the dura, you said slight retraction, but that looked like a fairly robust amount of retraction. That was in the upper thoracic cord, right?
Yes, but he wasn't retracting the thecal sac. He's actually retracting the muscles here. So this is
I see.
so what he's
I
showing is that
misinterpreted that.
yeah, so what he's showing is that he's using his finger to dissect the muscles, not the, I know it kind of does look like the cord a little bit,
Okay.
but he's actually coming lateral to the muscles and diving down onto the facet joints here to find the entry point for the pedicle screws.
All right. Thank you for clarifying that. That's cool.
Yeah, but Frank, I mean, that plane is also where the all the blood vessels that perfuse these muscles are are coming from. So I'm not sure. It's an interesting concept, this wheelchair approach in the thoracic spine, but I see both some technical difficulties trying to pass the rod under the muscles. I see some challenges, and those from a conceptual standpoint, again, you might already be impairing the perfusion of this of the musculature. I think that the concept of soft landing, you mentioned the Mercilin tape. It's definitely very, very interesting, but we've tried to do that, but trying to tighten that Mercilin tape is not really that easy, So I think there is room for some kind of new instrumentation or kind of room for improvement, on that concept. I think that's probably the one with the greatest potential from a technical standpoint to reduce the risk for PJK.
Yeah, I think utilizing our biodesign resources might be beneficial for something like that, to develop some sort of a new type of instrumentation that can maybe like a spinous process hook almost, or some sort of like almost rubbery type screw or rod at the end to prevent this from occurring.
Because also with the Mercilin tape, if you're able to tighten it, then it's not really elastic. So you need a little bit of elasticity on that.
All right. Thanks a lot, Frank. Thanks, everybody. Give me a second to transition the live stream.